Hey, everybody. So, we're talking about health professionals and what happens after the diagnosis, or at least the syndrome has been identified. And I want to be real clear that those are two different categories, and yet often they're treated as the same thing. And it's not. I mean, that is not the same. Knowing exactly what I'm living with or what some things that I'm living with are, and sort of knowing that I'm dealing with this specific kind of thing that I'm going to be living with, and I'm going to be trying to figure out how to manage, and the people around me are going to be figuring out it's what. It could be a very different phenomena. And so whether we're talking about actually getting a diagnosis, which is what type or types of dementia are we talking about here, and then getting a syndrome. I think what we're dealing with some neurodegeneration condition that we aren't going to be able to fix. We're going to want to figure out how to manage and deal with as a chronic, but here's the tricky part, progressive condition. Okay. And so one of the things that people frequently want to know, well, like, where are we? And, what are we talking about here? How long are we talking about? If we're talking about something that eventually we will identify it, or we need to identify it, this is a condition that ultimately will lead to a place where you will not be able to live with this amount of brain change. And so it is ultimately terminal. I don't want to focus on that right now, unless we're coming into this so late that we're really there. And this is the first time it's been addressed. Now, we would think that is got to be such a rare occasion that surely, that's very, very rare. So Matthew and people out there, what do you think is, how many people are diagnosed, do you think, what percent of everybody is diagnosed in the early state of their brain change? Like really, really early. Like maybe even the transition between this doesn't look like any kind of just side effect or normal of anything. I don't think, I can't just, it's not getting better. It's this, it's that. Very, very early on, I'm seeing a pattern emerge. It does run in the family, genetics or something. What percent do you think get caught in the early state of this, Matthew? Because we talk a lot to people who are early in the condition, so it can be tricky. What do you think the percent is at a international level, though?
I think it'd be pretty small, Teepa. We talked about before about how for folks, especially in that early state of dementia, that ability when we are being tested for our brain to like kick into overdrive and be able to look good and do everything right. But then what happens to us afterwards? So that's why I'm thinking it's pretty small.
Yeah, the maximum we expect, right? Actually, we know about, and it's really different in some developed nations than undeveloped nations. It's even worse. The maximum is about 20%. And that's where people are actually going into situations thinking, wow, what's going on here? And you have somebody who's pretty careful about monitoring. We know that in fact, only about 1% of people are being monitored for their cognitive status on a regular basis. Unless there've been some yellow flags or red flags, rarely are people looking at it on a regular basis. So looking at it and sort of investigating it just doesn't happen unless somebody points something out as a problem, an issue. So we've talked about that before, which means somewhere around 75%, between 70-75% of people who are going in for the very first time to get something looked at are in the middle of the condition. They aren't in the early state of the condition. They have been experiencing symptoms and worsening of symptoms and changing of symptoms and things that are affecting life, because the definition of this thing, the neurodegenerative disease we're talking about, is it's changing your ability to live your life. It's affecting at least two parts of your brain in significant ways so that your brain is dying in those areas. And we have brain loss. We have brain cell loss. We have brain function loss in those areas. And although the function loss could be coming and going, the brain destruction is real. And so it's solid. It's not, we're in the middle, 5 to 8 years of things getting more and more and more obvious before somebody goes, Or it could be still a total surprise for people. And if that's the case, this could be, this could be a real shocker. to figure out that what I'm talking about is not like having had a stroke and it's getting better, having depression that we could treat, having anxiety that we can manage, having diabetes that's not just poorly managed. There's something more going on here, having hypertension, but it's not just because I'm not taking my meds right. That whole idea that my Parkinson's isn't just Parkinson's, that these UTIs are due to. And so we actually start to recognize, oh, so the idea that I'm getting this thing labeled as what it is, even in a syndrome, can be pretty devastating. And for 70 to 75% of folks, they're in the middle of the condition at this point. This isn't a new thing, but people are having to rethink and relook and remember. And so it's estimated that a huge number of people, once they hear the words, we think you have some kind of dementia, we think you have dementia, they hear nothing else in that session. That from then on, boom, they either go into it's a primitive brain reaction. It's a fright, flight, fight, hide or seek reaction. It's an amygdala reaction. It's a threat reaction. What you've said takes away everything. And yet it doesn't, but it feels like it. And so what it does is I'm not going to be able to get any more data in right then. So if that's the case, that the person is going into fright, flight, fight, hide, or seek mode, what do you think the very first thing that I recommend people should be doing that they're not doing is? We need to call a pause. We need to do a timeout. We go, and this is how my recommendation, how this should be approached. So Matthew, you came in and we were doing a workup. I'm really been working on some things, trying to figure out what's going on for you. Tell me a little bit about what you're thinking is going on and why you came to me. Tell me a little bit about that. Yes. And I would say the same thing to your care partner if they were with you. Yes. What do I need to hear?
So talking about, okay, when did you start to notice this, that what you talked about last time, that idea of, okay, when did you first start noticing some of these things? What was going on? What brought you to the point?
So what Matthew was describing is, now I know what I think is going on for you. I need to check back in as a medical provider and go, okay, so what did you think was going on and where are you? If I'm going to deliver some information to you that I know is going to wipe out your thinking brain, if I want data about what brought you in and where you were and where your partner or friend or support person is, I better get that done before I give you this data. Because high probability, once I give you that data, you're done. And how I deliver that data, for me, and I think for any skilled medical provider, should be based on who I'm talking to. My mom had Alzheimer's is a statement. And so I'm afraid I might have that. So you're afraid that you might have what your mom had. Okay. And she had Alzheimer's, or how long ago was it? Because I want to, again, figure out, what do they really know about the different types of dementia, the different conditions? Because a lot of things got labeled as quote unquote Alzheimer's if people were older, and it may or may not have been Alzheimer's. I mean, so the idea of Alzheimer's plus with psychoses and hallucinations is like, as we look back, if that happened about 10 years ago, high probability, it could have been Lewy body disease. I mean, maybe with some vascular, maybe with Alzheimer's, but this idea that people know for sure what was going on 10 years ago, medical providers didn't know 10 years ago. We have only really started these centers of excellence in Lewy body disease, as an example, very, very recently. And we're still struggling with FTD in a major way for providers to clearly understand it. And vascular dementia, it gets short shrift. I mean, if it's not a stroke, people sort of or cardiac, it's like people get excited about the things they can fix and not the ones that are these slow progressive kinds of things, congestive heart failure, COPD, things, diabetes that's poorly managed. And so, there's a lot to figure out before we take that next step. But here's what I'm going to say. Once you do establish, and could be one person is able to get it, one person is not. What I think we are looking at, it's going to be something that it's already changed your life some. And I think we're going to be talking about how we're going to manage these new changes, this new normal for you. So I want you to sort of get your head around this idea, and I want you to come back in a week, because that's when we're going to talk more about this. I do think that what's going on is something we're going to have to manage that we're not necessarily going to be able to fix. And I think it's under the umbrella of a neurodegeneration, what people these days refer to as a dementia. But I tend to look at it as a ever-changing disability that's progressive. And that's what I want you to hear, is that's how we're going to cope with it and deal with it. And that's how we're going to move forward with it. Now, how often do you think that conversation happens like that, Matthew?
Very rare. I think that's very rare.
Do you think it makes sense though?
Yeah. I mean, I think for many of us, even if we haven't been through a situation where we've gone to a doctor's appointment with a loved one who just got a diagnosis, we've had moments in our life where we've gotten some shocking news, something that was like huge. And how many of us can raise our hands and say, oh yeah, I fully recall everything that happened after that. So why in this situation, the same thing, the same idea, this news being what it is, calling that pause.
Yeah. And if the person came in alone to get this, I mean, it's like, I'm going to ask you a really important question. If this is something that we need to deal with and it's big, who would you bring forward as a support, if anyone? And if you don't, how can we start working on that? Because this thing that you have, this condition you have, at some point, you without a doubt are going to need support in the form of a human being. So we want to start looking at that. But for right now, I want you to know I'm with you. We're going to work on this. And if we have a health provider who's not able to devote that energy and that time, that's not their practice, they need to have somebody to refer to who has those skill sets, because that's really what's going to be needed. So we're going to pause here because we need to pause, because I just said we need to pause. And the hard part for us is stopping. And yet being supportive. This could have come as a shock. This could be confirmation of what you were thinking. Whichever it is, we're going to meet again. I already have an appointment set up for you to come back, because we need to talk about this. And I want you to think, what's your first questions for me? And give yourself a few days, or it could be the end of the week. But people need a little time, so we can establish how much time. But we need to pause before we go elsewhere, because this is big news. So there you go. Our segment for today for medical providers. Matthew, any thoughts at the last second here before we pause?
Yeah, and just to let everybody know, so what we'll do here is this week will be about the healthcare professionals. And then next week we'll look at, the caregivers from the caregiver perspective. So that'll be
caregiver. Yeah.
So that'll be our next part of this set of series. And then that third and final part will be the folks who are living with dementia, and for them, those steps and those pieces. So we're going to bring that all together, because you all had so many great questions about, what about from a caregiver's perspective? And what about someone who's living with perspective? So we're setting that up so we can cover each one of those areas.
All right, everybody. Till next time, take care with care. We'll see you again tomorrow.
Bye, everybody.